How are you? Good. Thanks for coming.
Well, that was amazing, both of you guys. I mean, covered so much in so little time, did an impossible task, and a lot is coming at us here so quickly, and things are changing quite quickly. There's a lot of data to throw at us, new technologies that are available, and the question is, with this data, how do we apply it today in our clinic? And I think that that's probably the challenge, and as trials are rising, how we kind of, as the standards are changing, how do we put on these trials that are emerging, and how do we practice with this technology today in the absence of data? So I'm going to walk through a couple of cases just to illustrate, but this one also is, had been treated over time with metastatic, presented with in 2016 with a PSA of 534, had a prostate biopsy, showed Gleason 9, had bone scan that essentially showed high volume disease. CT at the time in 2016 showed nodal metastases and bone metastases with serum bicalutamide and Lupron, and got 6 cycles of docetaxel, which at the time, this was the charted era, so got docetaxel, pre-Arasense, pre-what we do today, obviously. And the PSA nadered down to 2, and then increased to 6.2, 9.2 by 2018. And there was stable bone metastases, got Sipuleucel T. At the time, there wasn't all that much available at the time, but that's what they got. PSA was 32, and continued PSA rising. By 2018, the PSA had gone up to 88, and enzalutamide was started. There was, at the time, no tissue available for, and tried to biopsy, and we couldn't get sequencing off of that. He then enrolled in the Checkmate 7DX trial, got docetaxel again with plus or minus nivolumab, and got 10 cycles of docetaxel, and was maintained on plus or minus nivo. So then started progressing, and we sent off Garden 360. It showed a point, as you can see, a 0.2% ATM mutation, otherwise nothing actionable. And we couldn't get additional sequencing, and he never got germline testing because of a large out-of-pocket for him. So I'm going to start with you guys. So obviously we have a lot of molecular profiling and genetic testing that I think has become standard of care, definitely in the CRPC space. I'm going to ask each of you, and Tian touched on it before, tissue is the standard, but do you all tend to do tissue, liquid, and germline testing? If so, which? Do you do all of them, all the above? So I'm going to ask you, each of you, and then I'm going to ask you also, is it in the hormone-sensitive space or for CRPC space? All right? So, Tian, you already had touched on it before. So.
I do send for all of my patients with metastatic disease. I would prefer usually to send tissue, but if they don't have tissue available, we'll send circulating tumor, so liquid biopsies. And then germline, I do think about also reflexively for everybody who's coming in with metastatic hormone-sensitive prostate cancer. By the time they get to castration resistance, they've already had some germline testing. But I do think it's very meaningful for patients, especially if we find those BRCA2, BRCA1, ATM that could potentially run in families. And so we have a very large genetic counselor group that's also at hand to help patients navigate those situations and help their family members access testing too.
Great. Dan?
Yeah, definitely get molecular testing done along similar lines. Germline, get it done early so you get the answer. I think, over time, those things are more actionable when you get to CRPC right now. We have those ongoing trials for castrate-sensitive disease. They're exploring the role of all these agents up front or earlier. But right now, I think the greatest value, the applicability is CRPC, but you want to know that information so that if the patient's progressing, you get that information, not waiting for the results. I tend, so germline for sure, somatic as well. I tend to do liquid if they only have bone mets. If they have a lot of bone mets, you can do biopsy as well. But if they have lymph node biopsy, then or other masses, I'll definitely favor tissue as well. And if they have liver mets, for sure, I get liver biopsy because I want to know the histology as well from the liver mets to make sure there's no transformation. The tissue testing is getting better and better even from bone now, so it's kind of a, no distinction there, but generally if there's only bone mets or just a few bone mets, I may get, liquid only, at least initially. Now the ATM is usually not actionable, right? So we know without information that those, the PARP inhibitors do not seem to work for ATM, so that's...
We'll touch on that in a second,
yeah.
for sure. And Charles, do you get wait till CRPC, or do you get front end right on?
Yeah, so everyone newly diagnosed metastatic hormone-sensitive prostate cancer, I do get germline testing, like everyone has said earlier, because it can be very important for cascade testing for family members and potentially planning for downstream targeting. But certainly the targeted therapies are more applicable as of now based on the CRPC setting. So I try to get for biopsies for somatic NGS. Like Dan was saying, sometimes getting the DNA yield might be tricky with bone mets. So circulating tumor DNA certainly has a role in capturing those mutations. I try to repeat the ctDNA a couple times at CRPC because these patients may acquire mutations, so you never know if you're going to pick up something. So.
Yeah, and I was going to ask that too. I also, in my practice too, and I'm sure you guys too, as there's clearly treatment emergent mutations that occur that sometimes you'll find. I assume that's the same in you guys' practice, and yeah. So now this is so. What's the implications, Tian, of this ATM mutation? With prognosis, what's the treatment implications here?
Yeah, so you've heard Dan allude to this already, but we do see less activity of PARP inhibitors in ATM, less so than BRCA1/2, for example. However, it's present, although in very small amounts in this particular patient. And if I had to guess, the P53 on this panel is probably driving more aggressive disease at this point. But if we're out of standard of care options and we wanted to see if it works, I've had patients with ATM alterations respond. Stable disease, they don't usually get to objective responses, but stable disease for a little bit of time. So we get some time on PARP inhibition. But I would say this particular case is probably being driven from that P53 alteration.
So yeah, so in so PARP inhibition, would you then use a single agent PARP inhibitor, or would you look to, is there a synergy, obviously in the BRCA way that you presented before, in BRCA mutations, and I think ATM was included in that, so would you think towards synergy there in this setting, or only earlier on?
Well, so I'd be curious to hear what Dan and Charles would do too, but I think of the clonal populations as a little bit, some are AR driven, some are maybe ATM and DNA damage driven. But if you give that combination, it's not really synergy, but helping the multiple different clones that are in heterogeneous prostate cancer. And so you get that upfront benefit. Will it work with this particular alteration in the setting of also P53 and beta-catenin? I'm not so sure.
So you would use single agent?
I would probably, well, he had prior ENZA and ABI, which technically is not the patient population of any of the trials. And he also, blew through abiraterone. So I would probably try the combination, but it's hard to say that he'll have much benefit from the AR-targeted therapy.
Dan, single agent or combo? And I want to know it early on and now, like at the beginning.
Yeah, so for ATM, I have not been using PARP inhibitor. I really think the activity is minimal, so I would not favor PARP for a case like this, especially if you had other options, lutetium PSMA, more chemotherapy, et cetera, with the P53, I'd favor going down other routes. We actually have a trial with a novel agent in the DNA repair pathway that allows for ATM, so I'd favor doing that as opposed to doing a PARP inhibitor just for the ATM. But that being said, if this was a BRCA case as an example, I would favor, just like Tian said, using it earlier. I think the synergy is real, appears to be real. But again, the therapeutic space matters. I think all these trials where the combination was for early CRPC. Most of those patients had not had exposure to ER inhibitors before. So this patient, as an example, had enzalutamide for CRPC. So this is already a late line post-AR patient. It's really not the patient where the synergy was really seen. So yeah, if I had a patient with the BRCA mutation that had minimal prior ER inhibitor in the hormone-sensitive setting and had not been heavily pretreated with AR, I would definitely consider the PARP plus AR inhibitor combination, but this late line, regardless of the ATM, but even if this was BRCA, this late line, I think it's more controversial.
Charles,
I don't think I would do it.
Yeah, ATM is very tricky. So currently, olaparib is FDA approved for a broad group of genes, but in the subset analysis, I think there's some questionable activity, but it is approved, so it is something to consider with the patient. But like everyone has said, the patient population has already had prior AR pathway inhibitors that we're seeing. So the combination, it's a little bit unclear, but we certainly buy into the synergy of the mechanism, so it's possible.
Yeah. So I mean, in this case, he got abiraterone, blew through it, just like rapid progression, got then cabazitaxel, and had 3 cycles and had a lot of side effects and stopped. And then PSMA PET showed markedly avid bone mets and also in I think there was nodal metastases in the prostate, and the SUV was 30 nearly. PSA was 691. So got lutetium PSMA and had and we saw the data that Tian had presented, which was very interesting and should have responded and seemed to have responded. Completed 6 cycles, but had some terrible cytopenias here. So, and in the interest of time, we won't talk about the. I guess we can talk a little bit about the intensity of PSMA uptake. But would that drive where you sequence this? Would you bring it earlier if you had more intense PSMA on? Yeah, like how early would you bring it? Like even pre-docetaxel?
So PSMA-4 was lutetium in that pre-Abienza treated patients but hadn't had chemotherapy exposure. So if he had a PSMA PET positive disease prior to giving him cabazitaxel, for example, you could consider it there. The label has not expanded quite yet, but we haven't had problems if patients have had docetaxel early on to get lutetium covered. So I do think if that PSMA positive disease is quite avid and prevalent in him with widespread bone disease, then I would try for lutetium over cabazitaxel.
Yeah, and do you feel, all of you can answer, but do you feel that is the best biomarker that we have? Is it PSMA PET? In other words, independent of histology. If you have aggressive histology or aggressive variant disease, but there's high PSMA uptake, is that a good enough biomarker to drive us more toward lutetium PSMA?
Is that for me?
Either of you, yeah.
I'll go first. I think it's a very complicated topic. My sense in clinic, I use multiple biomarkers together. I don't know which one is the most relevant. I like the SUV uptake in that 4th quartile to use, and I totally agree that I think as the PSMA-4 data becomes stronger, I think it's a strong consideration to use earlier. But you have to look at the total picture. I think you look at the SUV uptake, you look at the pattern of metastatic disease, liver mets, they tend to do worse. You re-biopsy those patients, you make sure they don't have transformation with small cell histology, which also does worse. So you use all these things, together to make a judgment call. And, you do have other options like the cabazitaxel. There's a SWOG study combining cabazi with carboplatin now that the patient population can have. So you put out all that into perspective. I think the challenge with the lutetium PSMA is that most patients don't have a great PSA response, even if it's working. You can see your patient had some PSA response, but it just came down to the 300s. It's not like a patient who gets hormonal therapy that goes from 200 down to 1. So it becomes very challenging. I also have seen kind of variable uptake of restaging during PSMA PET. You give 6 cycles. The trial was restaging every 2 cycles. Is this something that we're all really doing in practice or not? I don't know. That's been my practice. But I think it can be quite challenging to know if a patient with aggressive histology is or is not responding to the PSMA PET. And if you don't know that, you're sort of committing them to 6 cycles, which is essentially almost 8 to 9 months of therapy.
Yeah.
And the risk after doing all this is that you end up with those delayed cytopenias, right? Which again is something that we're learning more, and there's some debate about, is the cytopenias that we saw in the trials really what we're seeing in practice? Is it more, is it less? I've seen a lot of delayed cytopenias, and the challenge is that you get those 9 months done. It may have worked, it may not have worked. It's a little bit, do you believe the data or not? And then at the end, you have all these cytopenias, and it becomes very hard to give cabazitaxel. So it's a very, very difficult decision up front to say, I'm going to give you all the chemo first and then save the lutetium PSMA for later or first, knowing that you may not be able to give chemo later. So it's very complicated.
Yeah, that is complicated, and I think it's one of the biggest problems that I think we face with this stuff. And Charles, how do you manage that, like in terms of delayed cytopenias? Do you dose reduce? Do you dose adjust? How do you deal with that kind of thing? Because I think it's something that we see in practice all too much. And does that influence your sequencing?
Yeah, I tend to favor doing Pluvicto after docetaxel based on the current indication, but before cabazitaxel, because if patients have had docetaxel and then cabazitaxel, their marrow is just really tired and burned out. So I kind of like doing the
especially they had pelvic radiation.
Exactly.
And
some of these had palliative radiation or prostate radiation, so their marrow reserves are pretty burned out when we see them getting Pluvicto. So I tend to use it earlier. The struggle is that when we were at academic centers, a lot of the community referrals, they kind of exhaust their chemotherapy options first, and then they send them for Pluvicto. But then they have cytopenia issues, right? So we're kind of in a holding area where we might have to consider dose reductions. I think the starting dose is 200 millicuries, but then you can go down to 160. But it's always in consultation with our nuclear medicine folks and kind of seeing what's the safety in terms of the hemoglobin platelets parameters.
Yeah. Okay, I had an amazing case, another case, but we ran out of time. It was a great bladder case. I thought it was a great discussion, but I'm so sorry, guys, but next time. So thank you.
Right.
Thank you, guys. That was a fantastic discussion, fantastic presentation.
One
Dr.
question.
Vidal has a question over here.
Practical question. PSMA versus FDG, what's the concordance? And what percentage of your population are actually PSMA positive?
I think it depends on their biology. So the PSA high folks usually are PSMA positive. And the so people who you see with, single digits, teens, but widely metastatic disease on their, so teens on their PSA, but widely metastatic disease on their scans, they tend to be more FDG positive. So that discordance is what I look for. And so, I don't always get both FDG and PSMA PETs. So, therapy, by doing that, they kind of gave us very clear pictures of who is more anaplastic, who is PSMA positive, and more likely to benefit from lutetium. But in our usual practice, I'm not getting FDG with the PSMA PETs routinely in that setting. Unless I have a PSMA PET negative patient, but very aggressive disease, then I might go after the FDG PET to see what kind of anaplastic disease they have. And that patient population, I think, chemotherapies trials. We have some really exciting antibody-drug conjugates and bispecific agents coming through that hopefully those anaplastic patients will also respond to.
Actually, on that, like to just add on, radioligand therapy is obviously, it's somewhat of a platform technology, sort of. And are there in development radioligand therapies beyond PSMA as a target in prostate cancer that might then make FDG more topical? And where are we on development on that, if you guys are aware of anything?
You probably have some trials open.
Yeah, I mean, usually there's an inverse correlation, you know, like if you're gonna have a PSMA negative PSMA PET, you're gonna have a positive FDG PET. Is exactly this, it's about the biology. So the patients with the liver mets, the patients with transformation to small cell are the ones that, you know, will have more of the FDG part and not the PSMA. But I think we all start with because we're all thinking about, you know, lutetium PSMA eligibility, we all start with the PSMA PET. If I had a patient that I knew had liver mets and I knew already had transformed to small cell, I probably would do FDG. But for 95+% of cases, we start with the PSMA PET. But that being said, if they are transforming, then that's a subject that's a lot of investigation going on exactly on those transformation patients. We have a trial. It's a platform trial and multiple different agents exploring immunotherapy and other agents for these neuroendocrine transformation trials. So a lot of places, you know, have that.
And to answer more directly, so PSMA is a really good target for prostate cancer, but there are newer targets out. Janssen has a couple of trials coming through for KLK2, so be on the lookout for KLK2 in prostate cancer. And there's B7H3 is highly expressed on prostate cancer cells as well. So those are two that I'm keeping my eye on.
Yeah, and I think also the other thing to note for the radoncs in the room who are excited about this is alpha emitting versus beta emitting as well. Is there's play in that aspect of it as well. So I think it's going to continue to develop. I think it's exciting to see that you create one platform and break a little bit and then keep pushing it forward. So I think the future is good, and we look forward to seeing you all next year to discuss GU.